Yes, sir.
Please introduce Dr. Ravi.
Hello.
Dr. Ravi Mer can introduce कर दो भाई.
Sure, sir. I'll do it. Dr. Ravi needs no introduction. He has been my colleague, and he's already told you, Dr. Raman, that he is working as the director professor in Lady Harding Medical College, and he is very well versed with endoscopic surgeries. So that's where his field of specialization in otology is concerned. And we all will be highly sort of enriched by his experience by endoscopic. The treatment of otosclerosis, that is stepidotomy also. So, Ravi, I think let's start with your lecture without wasting any more time.
So, thank you, Dr. Gautam and Dr. Anil, sir. Uh, at the outset, I would like to thank.
Hello, Ravi.
We have
Can
Dr. JC Pasi sir also on the board.
Good evening, sir.
Yes, sir, I only want to say hi. Please start.
Good evening, sir.
Good evening. Good evening.
And
So-
my very good evening to the moderators.
Good evening, sir. Good evening.
Good evening.
So, at the outset, I would like to thank the Haryana IOI and the executive members, Dr. Surendra Singhal and Rupinder Ranga, for inviting me here. And thanks the moderators for introducing me. So my topic for today is otosclerosis, and this is going to be a basic talk on otosclerosis. I have covered all the aspects of otosclerosis in this talk, and after the talk, I will show you a video of endoscopic stepidotomy. So let me share my screen. So can you see my screen?
Yes. Yes, sir. You can see.
Yes, we can.
Okay. So history of otosclerosis is very interesting, and I will advise all the residents to definitely read the history. It's beautifully given in OCNA. And if you see, otosclerosis term was actually coined by von Rost, and Valsalva actually described the first case of stapes ankylosis in temporal bone dissection. And then later on, Kissel was the first person to do stapes surgery by mobilization. And the real action actually in the stapes surgery came when Holmgren started doing 3-staged fenestration operation, followed by Schodel, who actually performed 2-stage, and then the Lampert. Lampert was the first person to perform fenestration operation single stage, and he was the most famous otosclerosis surgeon in his time. And Lampert actually did not have any formal residency because he was from a poor background, and he did not actually have a formal residency in ENT, but he went to different ENT surgeons and did observership and started doing otology practice. So he was the first most successful, I would say, stapes surgeon, and he started doing single stage fenestration operation. And the modern stapes surgery actually was started by John Shea, and he's supposed to be the father of modern stapes surgery when he did use a piston for the first time and made the assembly from the foot plate to the incus. So that is the history. So what is the etopathogenesis? Otosclerosis is primarily a bony disease, that's a metabolic bony disease which affects the enchondral bone of the otic capsule, and it also affects the ossicles. So what happens? There is a increased action of the osteoclast, and there is bone resorption, and there is a bone formation. So there's alternating phases of bone resorption and formation, and it leads to change in the bone character from the lamellar bone to a spongy bone, and which is more vascular bone. And later on, there is a sclerosis. So that is the bone changes which are seen in the otosclerosis. It leads to fixation of the stapes foot plate. When the stapes foot plate becomes fixed, it leads to conductive hearing loss. when the otosclerotic foci actually involves the cochlea, it also leads to involvement of the labyrinth and leading to mixed hearing loss. And some of the patients, less than 10% of the patient, will actually present with sensorineural hearing loss. So epidemiology, it is a disease of white race. So mainly Caucasian population is affected. Asians are also affected. It is very, very rare in Native Americans. And the overall prevalence of histological otosclerosis. Histological otosclerosis means that there is a otosclerotic changes in the otic capsule around the stapes footplate area, but the patient is not clinically symptomatic. So that is histological otosclerosis, and the overall prevalence of clinically significant otosclerosis is just 1%. So you might have histological otosclerotic changes in many of the temporal bones, but the clinical symptoms is seen in only 1/10 of the patients. So the clinical otosclerosis is more commonly seen in women than the men, and it is actually involves bilateral ear. It may be asymmetrical initially, but later on there can be symmetrical hearing losses in both the ears. There is a rapid progression in the pregnancy, and 15 to 45 years is the most common age of presentation. So what is the etiology? The exact etiology we don't know. It is supposed to be congenital. 2/3 of the patients will have some family history. The penetration, the hereditary component is basically autosomal dominant with incomplete penetration. There are certain genetic focus also which has been described in books. So there is some element of genetics, but there are two other hypotheses which have been proposed, that it is a measles virus which actually causes otosclerotic changes, and it is an autoimmune disease which actually leads to metabolic and endocrine disorders. But both of these hypotheses have not been conclusively proven. So what we exactly know right now is that there is a strong genetic component in the etiology of the disease. As I already told you, the mature lamellar bone is replaced by new spongy bone, which is more vascular and thick, right? There are two phases. Initial phase is active phase, which is the otospongiosis, and there is an inactive stage, which is called as otosclerosis, which is the end stage. So initially in otospongiotic stage, there is an active bone resorption because of the increased activity of osteoclast, and there is an increased vascularity, and it stains blue on H&E staining. So that is why it is called as blue mantles also. During inactive stage, there's a deposition of new bone. The sclerotic bone stains red and it is acidophilic. So that is the end stage of the disease, and it is called as otosclerosis. Okay. So most of the most common site, what the most common site? The most common site is the anterior part of the foot plate, and that is called as fistula antifenestrum. It can also involve the round window niche area. It can involve the cochlear labyrinth. It can involve the complete stapes foot plate and the posterior part of the oval window also. So if it is involving the stapes foot plate area, it will lead to conductive hearing loss. If it is involving the cochlear elements also, there can be sensorineural component to the hearing loss, and there can be vestibular symptoms also. Okay, so what are the different types of stapedial otosclerosis? There can be anterior foci, there can be posterior foci, there can be circumferential involvement of the foot plate, there can be biscuit type, and then there can be obliterative type. So obliterative type is the most difficult type otosclerosis to deal with. So how do you diagnose? Diagnosis, it is usually presents in 3rd to 4th decade of life. Patient has gradual onset of hearing, which is slow progressive. 70 to 80% patient will have bilateral. Initially, the hearing loss is asymmetrical, but later it can become symmetrical hearing loss. Patient has classically low volume speech, right? Because of the autophonia, the patient will have low volume speech because there's a conductive hearing loss. Patients with sensorineural hearing loss actually have a very high volume speech, right? So the patient speech will be very soft spoken patient. Then there is a paracusis velisae. This is a condition which is seen in any conductive hearing loss, but has been described with otosclerosis. And what the patient complains that he says that there is a better hearing in noisy environment, and that is because of the fact that in noisy environment we actually tend to raise our voice, and because we raise our voice, the patient's threshold of hearing is crossed and patient is able to hear better. So this paracusis villici is a phenomena which is described with otosclerosis, but can be seen in any conductive hearing loss. There can be other otological manifestation like tinnitus and vertigo. It depends on the involvement of otosclerotic foci and whether there is a cochlear component or not. There can be deterioration during pregnancy. Hearing loss may accelerate during the pregnancy, and there is a family history in almost 50% of the patient. On examination, you will find normal tympanic membrane, short sign, or which is also called as flamingo pink sign. It is seen in active foci. If there is an active foci or there is an otospongiotic foci in the foot plate, then you can see short sign, but it is not seen in all the patients. And it suggests that the disease is active. Tuning fork test is very, very important for any patients to for the diagnosis of otosclerosis, and a negative Rennes and Weber lateralized to Versier with normal ABC will corroborate the findings of otosclerosis. We can get audiometry, impedance audiometry. If you see the impedance audiometry, the compliance is actually reduced, right? So this is classical of otosclerosis, AS type of curve, and the acoustic reflexes are absent. So if the acoustic reflexes are present, then you should have some doubt about the diagnosis. Normally, in patients with otosclerosis, you should have a type A or AS type of curve on impedance, plus the acoustic reflex should be absent. If it is present, then there is a chance of third mobile window, or superior semicircumflex dehiscence syndrome. So that one should keep in mind. Speech discrimination score is usually normal unless there is a cochlear involvement. So this is about the impedance. In Puton audiometry, what we find that there is a conductive deafness, and there is a classical Carhart's notch, which is described as decrease in bone conduction at 2000 Hertz. So what is the reason of Carhart's notch? If you see the mechanism of bone conduction, there are three mechanisms of bone conduction, three routes of bone conduction rather. So one route is the direct skull vibration. So when you keep the vibrating tuning fork over the temporal region, the whole skull vibrates, and in turn vibrates the cochlea, and the patient is able to hear. So that is route A. Second route is through the vibration of the ossicular chain, which is suspended in the skull. So what happens when the skull is vibrating, the ossicle, which has an inertia, is not vibrating, right? So there's a relative movement of the ossicles with the perilimb, and that leads to some hearing, and this is called as inertial component, or through the ossicular chain. And route 3 is basically, or C is basically the normal route of conduction through the tympanic membrane, right? Through the external canal, through the tympanic membrane, and through the ossicle to the inner ear. So these are three routes. So what happens when the stapes foot plate is fixed, the route B and C are deficient. That means the only way by which the patient is hearing is through the bone vibration, the skull vibration. The transmission through the inertial component and the normal air conduction is lost. And what happens when this is lost? There is a loss of middle ear component, which is close to the resonance point of the ossicular chain. So the resonance point of the ossicular chain is actually 2000 Hertz. And that is why we have a dip at 2000 Hertz. And this dip, this is a pseudo dip, pseudo decrease in the bone conduction. Actually, there is no decrease, but it is seen on audiometry. So this actually reverses by after stapes surgery. If you do a good stapes surgery or a stapes mobilization, Carhart's notch should disappear. Imaging. When I was resident, we never used to do imaging of stapes, but it is important. And if you have the facility of imaging or radiological imaging at your institution, we must get a CT scan of the temporal bone in all patients of otosclerosis, because it gives you some extra information. And here you can see that there is a otospongotic foci, which is just anterior to the foot plate area, right? So, and the CT findings can be hypotense or hypolucent areas anterior to the oval window. The foot plate might appear thickened. There can be narrowing of the oval window or round window. You can actually see classical double ring or halo sign around the cochlea. This is a double ring or halo sign which is seen in cavitatory type of otosclerosis, and it suggests that there is a cochlear involvement. Right, irregular margin and scalloped edges of the otic capsule can also be seen. So HRCT should be recommended if you have a diagnosis which is in doubt. Suppose the reflexes are present and there's a conductive deafness, so you must get a HRCT to rule out superior canal descent syndrome, right? Or if the patient needs to be taken for revision surgery, we don't know what has happened in the previous surgery. What is the status of the piston or the prosthesis which you have inserted? So in cases of revision surgery, you can get a CT scan, and also in only hearing ear, we must get a CT scan. So there are other advantages also. CT findings can actually tell you the malleus head fixation. Normally the incus and the malleus actually are suspended in the attic, and when you get a CT scan, normal CT scan, you will find that these ossicles, the malleus and incus, are suspended in the attic, but there is no connection with the attic. In case of the malleus head fixation, the ligaments will become thick and they will be seen as attachment to the attic. So malleus head fixation, if you have a good CT scan, you can see. Incus fixation can also be seen. You can diagnose superior seminiconal descent syndrome. You must look for enlarged vestibular aqueduct. You must look for ossicular deformity, tympanosclerosis, congenital cholestoma, and Paget's disease. So these are all, in fact, differential diagnoses which can be actually picked up by CT scan. You should also look at the cochlear aqueduct, because if there's a dilated cochlear aqueduct, there is chances of perilymph leak or gusher during the surgery. Also, if there's an enlarged internal acoustic meatus, that also indicates that the patient might have gusher during the surgery. So these are the points which you must look at the CT scan. So here is the CT scan of a patient with Paget disease. So again, there can be osteogenesis imperfecta, where you can have loose sclera, multiple fractures, and progressive hearing loss. All these are actually differential diagnosis of otosclerosis. And then you can also have superior seminiconal descent syndrome, where you have descent of bone at the dome of the superior seminal canal, and patient has conductive hearing loss with Tullio's phenomena. That means the patient will have some vertigo during a loud sound. There can be it can be diagnosed on CT scan, and you can also confirm it by VEMP, or vestibular evoked myogenic potentials. So that was about the differential diagnosis. Now we come to management. So management options which are available are medical, amplification, that is the hearing aids, and the surgery. So regarding the medical management, just for completion's sake, there are two drugs which can be given for medical management: sodium fluoride and bisphosphonates. I do not have any experience of giving sodium fluoride or bisphosphonates for patients with otosclerosis. What is described in the books, I am just telling you the description which is given in standard textbooks. So the mechanism of the action of sodium fluoride is that it replaces the hydroxyl group in the bone, forming fluoroapatite. So this causes maturation of the active foci of otosclerosis. So this is actually given in patients who are having active foci, that is otospongotic. You have a flamingo pink sign, or you have a Schwartz sign positive. In these patients, you can actually give sodium fluoride. It actually inhibits the osteoclastic activity and increases the calcium deposition in the otospongotic foci, thus causing increase in the otosclerotic component and the final end of the disease. The dose, it is available by the name of Otoflow. Dose is 50 milligram for many months to years. Actually, it has to be given. It is indicated in non-surgical candidates, patients who do not want surgery, and surgical candidates with positive Schwartz sign, and patients who have progressive sensitive hearing loss. We must reevaluate the patient with CT scan and the Schwartz sign to resolve. Normally, in today's scenario, I don't think anybody is using sodium fluoride. So there are side effects also. The side effects are gastrointestinal side effects because it is a strong irritant. It can cause arthralgia, synovitis, GI disturbances, painful plantar fasciitis, anemia, and ligament calcification because it increases the calcification in the bone. Contraindications: chronic renal failure, pregnancy, children, allergy, and fluorosis. So you don't give the fluorides in these patients. So I'll go to bisphosphonates. Again, this has also been given in the textbook, standard textbook. So bisphosphonates is used for treatment of osteoporosis as well as for Paget disease. It is alternative to sodium fluoride, and it has a similar sort of action as sodium fluoride. It blocks the osteoclastic activity, reduces bone remodeling, and increases calcification. So there's slow reduction in the rate of progressive sensory hearing loss in the patient with cochlear otosclerosis. What are the adverse effects? It can actually cause radionecrosis of the jaw. It can lead to renal toxicity and erosive esophagitis. So this was about the drugs. We come to amplification. So this is a good option which patient can be offered. So when a patient with otosclerosis comes to you, you must give an option for hearing aids, because many of the patients actually will be presently surprised if they try a hearing aid. So they will be very happy if they are given for a hearing aid trial. But overall satisfaction is lower than a successful surgery. So we must give an option of hearing aids to the patient and let the patient decide whether he wants surgical intervention or amplification. The problem with the hearing aids is that it is not used at night. There's a device. There's a problem with recurrent maintenance of the device as well as otitis externa, and there's a difficulty with feedback, right? So there are problems with hearing aids. So patient satisfaction, overall satisfaction with the hearing aids is lower than the surgery. So what are the surgical options? How do you select your candidates? So the best surgical candidate is a patient who is not operated. He is in good health with unacceptable airborne gap. So there should be at least 15 decibel of airborne gap present. It should be seen by a negative Rini test. So if it is Rini is negative only by 256 Hertz, you can do stapes surgery. If it is negative with both 256 and 512, the patient is a good candidate. And if it is negative with all the three tuning forks, that means it is the best candidate because the patient will have more than 30 decibel of conductive deafness. And the patient should also be evaluated for any sensory component, and he should have excellent speech discrimination. So that is the best candidate for surgical intervention. What are the contraindications? So there are lots of contraindications given in your books, but active infection in the external aortic canal, if there's a CSOM or there's a perforation, it's a contraindication. We must treat the CSOM and the perforation first, and then later on take the patient for surgical intervention. If there's a unilateral disease, there are surgeons who will actually operate on unilateral disease, but a unilateral disease must be operated by a experienced stapes surgeon. Vestibular symptoms, if the patient has vertigo and tinnitus also along with hearing loss, then we should rule out Meniere's syndrome. If there's a only hearing ear, revision surgery, second ear surgery, these are all relative contraindications, and there are surgeons who will actually operate, because in today's world, if the patient is having unilateral hearing loss, he is not able to participate in meetings, and he is not able to do his daily activity, then there is an indication for second ear surgery, and many surgeons are doing second ear surgeries. Any patient who has sensorineural hearing loss, obviously otosclerosis will be contraindicated, and pregnancy is also one of the contraindications. After the delivery, the patient can undergo surgery. Preoperative counseling is very, very important. Though the surgical results are excellent and it's a very rewarding surgery, but there is definite component of sensorineural hearing loss which the patient can suffer after surgery. So a total sensorineural hearing loss or dead ear can actually occur in less than 0.2% of patients in good surgical hands, right? So this must be told to the patient. It should be told to the patient that there is a definite chance of sensorineural hearing loss, but it is very, very low. The risk is very, very low, right? There can be dizziness, which can occur post-operatively, and it is usually transient and brief. You should tell about the tinnitus, possible facial nerve palsy. There could be recurrent conductive hearing loss, alternation of the taste, because there can be manipulation of chorda tympani during the surgery, and flying and heavy work to be avoided during initial post-operative period. So this all things should be told to the patient preoperatively, and informed consent must be taken. So general versus local anesthesia. So it depends on the patient's preference and the surgeon's preference. At Maulana Azad Medical College, we are doing all stapes surgery under local anesthesia. The biggest advantage of local anesthesia is that you can actually check the hearing after you insert the prosthesis. So that is the immediate feedback which can be taken from the patient on table. You can also know if the patient is having vertigo, because if you have damaged the labyrinth, or if you've gone inside the vestibule, the patient will have vertigo on table. But again, this can be detrimental also for local anesthesia, because the patient can move a lot during this, and it can hamper your surgical procedure. General anesthesia, yes, people are doing, some of these surgeons across the world are doing general anesthesia because pain and head movements are not there, so that is an advantage. But again, you can't check the hearing on table with general anesthesia. So we'll go to the surgical steps. So you can do surgery with microscope, and or you can use an endoscope. The endoscopic stepidotomy is pretty much standardized now, and if there's a tortuous canal or stenotic canal, you can do an endoral incision. I have seen some of the surgeons doing a post-oral incision also for stapes surgery. There's no harm in that because it gives you an excellent exposure. You should have a self-retaining speculum or a holder which is attached to the operating table. Right. So first step is to give local anesthesia. We use 1:10,000 local anesthesia. A very high concentration of ADR is used, but it is used in very small quantity. So 1 ml of 2% lidocaine is sufficient to actually anesthetize the four walls of the canal. It should be given in bony cartilage junction, and you should avoid very medial injections because it can actually raise a bleb. So that will actually hamper. So in case there is a bleb formation in the canal, you can just pack it with ADR saline, and it will disappear with time and pressure. So you just have some patience, and you can actually tackle with this bleb also. Incision, classically it is Rosen's flap. Incision starts from 6 o'clock position to 12 o'clock position, and it is lateral. It should be lateral from the annulus about 6 to 8 millimeter. So this is very important. You should not raise a small thickness of the flap, because once you curate the bone from the posterior canal wall, the flap can fall short. So there should be at least 6 to 8 millimeter thickness of the flap. Then you raise the tympanic flap. Tympanometer flap is raised, and it is raised till the tympanic annulus, right? And what is the extent of raising the flap? You should be able to actually see the round window niche area. So this is a round window niche area which is seen. Superiorly, you should see the neck of the malleus. And when you are entering into the middle ear, you should use a sharp instrument like a curved needle or a bisturi, so that you can cut the middle ear mucosa with that, and you don't enter lateral to the tympanic membrane, because here you can actually go lateral to the tympanic membrane and cause a linear tear at the level of annulus. So this should be kept in mind, and you should use a sharp instrument to elevate. Next comes the chorda tympani. So chorda tympani is actually, if you see the chorda tympani is adherent to the posterior superior part of the canal wall, right? So while elevating the flap, you should enter the middle ear inferior to the chorda, right? And then gently separate the chorda and retract it anteriorly, right? So that is important to prevent injury to the chorda. Patients with otosclerosis will actually complain of taste alteration if you cut the chorda or if you stretch the chorda too much, right? So it is important to save the chorda, and if it is coming in way of your surgical exposure, then you can actually cut it rather than stretch it. So stretching should be avoided. Too much of stretching should be avoided for the chorda. Then you actually expose the posterior canal wall. To expose the stapes footplate area, you have to remove the posterior superior canal wall, right? And you can use a sharp curette to remove the posterior superior overhang. When you remove the posterior superior overhang, it should be very gentle, and you should not damage the incus, because at this point, while curettage, you can actually damage the tip of the curettage, can actually strike the long process of incus, and you can actually cause dislocation of incus. So at this point, it should be very gentle, and you should do it in vision. Under vision, it should be removed. You can use drill also. So a sharp curette, I like the instrument. A sharp curette is a good instrument because it gives you a good control also. What is the exposure? The extent of exposure. So this the extent of the exposure after curettage. So what you can see here is the facial nerve here, the stapedial tendon, the pyramidal process. This is the chorda tympani, the long process of incus, the IS joint, the posterior crura, and the foot plate. So this is the extent of exposure you should have, right? From the base of the pyramid to the malleus undersurface, and from the facial nerve till the round window. So this much of the exposure is important for stapes surgery. Middle examination. So now you actually check for the mobility of the ossicles. So you should check for the mobility of the malleus and the incus before checking the mobility of the stapes. So you basically move the malleus and see the mobility of the incus. And once you see that the malleus and the incus are mobile, then you check the mobility of the stapes. So for checking the mobility of stapes, don't move the stapes sideways. It should be pressed vertically, right? And then gently check for the mobility, and you will find that the stapes footplate is, or the stapes is not moving and it is fixed. You can also check for round window reflex at this point of time, and if there's no round window reflex, probably the stapes is fixed, right? So this is how you check for the mobility. Next step is to dislocate the incus, incudostapedial joint. So you can dislocate the incudostapedial joint with a right angle pick, or there's a joint knife also available. And once you dislocate the IS joint, you have to cut the stapedial tendon, right? So this stapedial tendon is cut, it should be cut closer to the pyramid so that it does not obstruct your view. After cutting the stapedial tendon, you have to remove the suprastructure. The suprastructure is removed by fracturing the posterior, because the posterior crura of the footplate is thicker than the anterior crura. So you should actually try to fracture the posterior crura first, and then go for the anterior crura, right? And you can use a sharp right angle pick to score the posterior crura near the footplate, or you can use a drill, or you can also use laser at this point. If you have laser at your disposal, you can use laser to evaporate the posterior crura and then the anterior crura and remove it, right? So this has been removed, the superstructure has been removed, and this is the stapes suprastructure. Now, next step is to measure the prosthesis. So this is very, very important. And how do you measure? You have to take the measuring rod, and the measurement is actually from the under surface of the incus long process till the footplate, right? So you take a measuring rod and try to measure from the under surface of the footplate till the from the under surface of the incus till the footplate, and add 0.25 millimeter. This 0.25 millimeter is added for the length of thickness of the footplate, because the piston, the middle end of the piston is going to enter into the footplate. So the thickness of the footplate is added, right? Normally the thickness of the footplate is around 0.15 millimeter to 0.4 millimeter. So the average of it is around 0.25 millimeters should be added to the length, which is calculated by the measuring rod. In cases of thick footplate or obliterative footplate, you should measure the length after blue lining the footplate, right? So because if there's a thick footplate, obviously you will have a shorter length. So it should be blue lined. If you should drill the obliterary foci, blue line the foot plate, and then measure it. How to perform fenestration? So there are different techniques for fenestration. I've been using Skeeter, and I've also used the perforator. So perforator is 0.7 millimeter perforator is used to put a piston of 0.6 millimeter, right? So if you're having a piston of 0.6 millimeter diameter, use a 0.7 millimeter diamond burr, or you use a 0.7 millimeter perforator to perforate the foot plate. What is the site of perforation? It is usually in the posterior half of the foot plate, because at this point, the distance of the membranous labyrinth from the undersurface of the foot plate is greatest. So you will not be actually damaging the membranous labyrinth, right? You can also use laser at this point of time to perforate the foot plate, right? When you are using a Skeeter, you don't have to put pressure, just touch the foot plate with the Skeeter and it will rotate. So basically drill out the foot plate, right? You don't have to push it, because if you put pressure, lot of pressure, it can lead to dislocation of the foot plate. Okay, so next is the oval window seal. So there are many surgeons who actually use vein graft, but for stapedectomy, it is a must, right? If you have done a stapedectomy, have removed the whole of the foot plate, you must put a vein graft or a temporal fascia graft. But for a normal stapes, when you are doing a stepedotomy, it is not necessary. I am not using any vein graft. We are doing stepedotomy and just inserting the piston. The blood around the piston will actually seal the foot plate area, right? So any of the following can be used: vein, tracheal pericorneal, temporal fascia, blood or fat to seal the stepedotomy, right? There are different types of prostheses: Teflon, titanium, nitinol, and the soft clip pistons are also available. We are using Teflon piston. These are good piston because they have a memory. And if you see the hearing gain with different pistons, there is not much difference. The studies do not suggest any difference in the hearing gain after using different type of pistons, right? So nitinol piston is actually, this is a nitinol piston. What it is it actually crimps on applying heat. So there's a special cautery to apply heat to the loop of the piston, and it will actually crimp on its own, right? So that is the advantage. There was a thesis in our department also. We did use some nitinol piston under the guidance of Dr. Pasi. So how do you place the prosthesis? So this is a Teflon piston, and the medial end of the piston actually should go into the foot plate first, right? So that is the most important. You can't insert the loop of the piston in the incus and then try to manipulate the lower end into the foot plate. That is not a good idea. So just hold the piston with the crocodile forceps, fine crocodile forceps from the loop up, and then straight away go into the stepedotomy which you have created. The lower end should enter the stepedotomy, and then you try to pass on the loop over the incus. Long process, right? And crimping is important. The Teflon piston has good memory, but if you have opened too much, then you need to crimp the piston, right? So wire is crimped by crimping forceps, and there is a nitinol process which I told you that requires heating for crimping. On table, you must assess the hearing status, reposit the flap, and on table check the hearing improvement, right? And it is very, very rewarding surgery. As soon as you reposit the flap, patient is able to hear on table. So something about the total stapedectomy. Earlier, people used to do total stapedectomy. Now it is not, but there are certain conditions in which you have to do total stapedectomy, and these are like floating foot plate. If you have actually traumatized the foot plate that is gone inside, then you can't help. You have to cover the foot plate area with a vein graft. or a temporal fascia and complete the procedure, or fracture of the foot plate when there's an inadvertent removal of the foot plate along with the superstructure, and when there's extensive fixation of the foot plate, right? So in these cases, you might need to do a total stapedectomy. What are the disadvantages? Obviously, when you are removing the foot plate area, there's an increased chance of vestibular symptoms. Patient will have vertigo and nausea, vomiting in the postoperative period. Technically, it is more difficult. There are chances of process migration, and all the stapedectomies must be sealed with tissue graft, because there's a very high chance of perilymph leak and fistula formation. Stepedotomy, small fenestra surgery, obviously advantage. So there's definite advantages of small fenestra surgery, and that is why we are doing stepedotomies nowadays. And there's less chance of cochlear trauma, less release of proteolytic enzyme from the foci, limits the loss of perilymph. There's less blood entry into the vestibule, less incidence of process migration, less fixation of the process by scar tissue, and there's less complication like sensitive hearing loss at perilymph, fistula, and vertigo. So obviously, stepedotomy is the surgery which should be done at present, and stapedectomy is to be avoided. There is another procedure which is called a stamp. It has been described in books. I have not been able to perform stamp any time, but definitely it is given in books, and the residents should know. It is basically stepedotomy minus prosthesis. And what you do actually, this is the foot, this superstructure, the anterior part, because anterior part of the foot plate is involved. So it is done in patients with otosclerotic foci only in the anterior part of the foot plate. So the anterior part of the foot plate as well as the anterior crura is removed. The posterior part of the foot plate and the posterior crura is left intact, and that means it is free to move, and patient can hear from this. So there's no prosthesis involved in these patients, and the posterior half of the foot plate and the crura actually becomes mobile and gives hearing to the patient, right? So the advantage is that it has an intact stapedial tendon also, so it will prevent hyperacusis and reduction in the long-term postoperative inner ear injuries, right? There are no process complications, but it's a difficult technique and it cannot be done in all the patients. It can be done only in patients who have anterior foci of the otosclerosis. Reverse stepedotomy, this is also described by Hugo Fish. In this technique, what you do, you actually put the piston, you make a stepedotomy and you put the piston before removing the suprastructure. So this, in fact, actually helps to prevent any floating foot plates or trauma to the foot plate while removal of the suprastructure. So because the whole assembly is intact, the suprastructure is intact, the stable tendon is also intact, there is very less chances of trauma to the foot plate and less chances of foot plate dislocation and floating foot plate. So that is the advantage of reverse stepedotomy, but it cannot be done in all the patients because of the exposure. The foot plate, you should have a good exposure of the foot plate to do stepedotomy and put a piston. So laser in stapes surgery, yes, there have been lots of progress, and now we have carbon dioxide laser which can be passed through fiber also. So this is a OmniGuide laser machine which uses carbon dioxide, and it has got a laser fiber, right? And this laser fiber is a handheld fiber, and it can be used to remove the posterior superstructure, posterior crura, as well as the stepedotomy. The advantage is that this bloodless fenestra, there's a reduced chances of foot plate subluxation. It avoids manipulation of foot plate. Laser is very advantageous in case of revision surgery, because in revision surgery there are lots of adhesions. So you can break the adhesions by laser, and it can help in removal of the prosthesis also in revision surgery. Disadvantage, high energy of the laser can actually damage the vestibule or the membranous labyrinth, and you can also inadvertently damage the facial nerve if you fire the laser close to the facial nerve, right? So this is about the laser. So So this is a rosette which has been formed by using a carbon dioxide handheld laser. And now, because now the foot plate is thinned out, you can use skeeter or drill to make a precise fenestra, right? So you can use carbon dioxide laser also, which can be a single shot carbon dioxide laser, which single shot can actually evaporate the foot plate and make a precise tapedotomy. You can use a KTP laser to make a rosette like this. You can use the laser to cut the stable tendon and in posterior crura, you can make the fenestra, and it is useful in revision cases to divide the fibrous adhesions. What is the post-operative care? We should avoid heavy work, Valsalva, nose blowing, sneezing with open mouth, and air travel after the surgery. Oral antibiotics for 1 week we usually give, and a PTA is done after 6 to 8 weeks, and airborne gap should close within 10 decibel. So what are special consideration and complication which can occur during surgery? So overhanging facial nerve. So the facial nerve actually can overhang and it can occlude the foot plate area. So if it occludes the foot plate area, you will not be able to perform stepedotomy and put the piston, right? And in 0.5% of the patient, you can actually have a significant descent and prolapse of the facial nerve. So what you can do, you can actually compress the facial nerve with 24 number suction and try to make a small space for the stepedotomy. In case you are not able to do that, you have to abandon the surgery, because otherwise you can actually damage the facial nerve if you continue. So abandoning the surgery is also one of the options. If you are expert, you can actually do a promontory drilling, and you can drill the promontory just inferior to the foot plate, and then do a insertion of the piston, right? So that can also be done, and it is advisable only for the experts to carry out this procedure. So perilymph fistula, perilymph leak, small amount of perilymph leak will occur in all the patients, and it is usually it heals after 24 hours, and within 24 hours any leak which is around the foot plate is it closes by the blood, right? And but there can be continuous perilymph leak if the patient has suffered barotrauma. For example, patient suffered from nose blowing or diving or flying, or if he lifts heavy weight. So in these cases, the barotrauma, there can be perilymph leak, and the patient can develop hearing loss, tinnitus, vertigo, and oral fullness. How can you prevent? It is good idea to perform interposition graft like vein graft. So it will seal the area. Stepedotomy also prevents perilymph fistula, because if you have a good fitting piston in this stepedotomy, there is hardly any chance of perilymph leak. If there's a perilymph leak, the management is bed rest. You can give Diamox to reduce the leak. You can give steroids. In case it does not settle down, you have to do a tympanotomy and close the fistula. Persistent stepadal artery. I have not encountered any case of persistent stepadal artery, but if it is present, then it may lead to difficulty during a stepedotomy and piston insertion. So what is it? It is actually a communication. It's a embological communication between the internal carotid artery and the external carotid artery, and it replaces the middle meningeal artery. So in case of persistent stepadal artery is present, the middle meningeal artery will be absent. So it can be seen on CT scan. If the foramen spinosum on CT scan is absent, it gives a clue that probably there is a persistent stepadal artery in this patient, right? It can bleed and lead to troublesome bleeding during surgery. How to manage? If it is located anterior to the foot, in the anterior part of the foot plate, you can do a stepedotomy in the posterior half. Sometimes you can actually displace, after removing the suprastructure, you can displace the artery and do a stepedotomy, which is often very difficult. Most of the time it has to be abandoned. there have been few case reports where you can actually do coagulation. Initially, coagulation of the stapedial artery was not advocated because people thought that if you coagulate the stapedial artery, patient will have hemiparesis and hemiplegia because it's supplying the brain. But now it has been proven that you can actually coagulate the artery and do the procedure. Floating foot plate. Again, this floating foot plate occurs when you have traumatized the suprastructure and you are trying to do a stepedotomy or trying to check for the mobility of the foot plate sideways. So the foot plate actually goes inside the labyrinth, and fishing of the foot plate is not recommended because fishing can cause more trauma to the inner ear, more trauma to the membranous labyrinth, and patient can develop complete sensory hearing loss. So ideally is to place a seal, place a fascia, and put a piston. How to prevent floating foot plate? You can do a stepedotomy, do a reverse stepedotomy because that will prevent any trauma to the foot plate. And you can also make a small control hole in the foot plate because in case there is a dislocation or a floating foot plate, this control hole can actually be used to fish out the foot plate, right? So these are the things which can be done to tackle floating foot plate. Obliterative foci. If there is an obliterative foci, you have to drill the obliterative foci. Use a diamond drill, 1.5 millimeter diamond drill to drill out the whole obliterative focus. And once you have a blue lining of the foot plate, then you measure it and then perform a stepedotomy. So again, this can be difficult for a novice, but it can be done by an experienced surgeon. Incus dislocation. So this is also common when you start your practice. In initial cases, you might encounter dislocation of the incus. So this dislocation occurs when you are curating the posterior part of this canal wall, right? So if there's a dislocation of the foot plate, a dislocation of the incus, and there's a complete dislocation, then you have to remove the incus. There's nothing you can do. The incus must come out, and you have to insert some prosthesis, which could be a incus replacement prosthesis or a TORP or total ossicular replacement prosthesis, right? So there's another technique which has been described by Robert Vincent, and what he does in cases of absent incus, he will cut the tensor tendini tendon and rotate or dislocate the malleus posteriorly so that the malleus actually lies over the foot plate, right? So he can make a vertical assembly from the foot plate to the malleus. So that is a malleus relocation technique which has been described. So that can also be done in patients where you have dislocated incus. Narrow oval window niche, again, if it is very slit-like, very narrow, you can do a drilling of the inferior lip of the foot plate and drill a part of the promontory also to make a fenestra, and then put a piston. Round window closer, this is also very, very rare. And if there is a complete obliteration of the round window by otosclerotic foci, patient can have conductive hearing loss, persistence of conductive hearing loss even after the surgery. And intraoperatively, how can you look at it? You can actually do a round window reflex, and that will be absent after a successful stepedotomy. So at that point of time, you should suspect that probably there's a round window closure. Opening of the round window by drilling is not advisable because it has been seen that it causes a lot of sensory hearing loss, right? So it's a difficult condition to treat. Sensory hearing loss, less than 1% of the patient may develop sensory hearing loss. It could be temporary because of serous labyrinthitis, or it could be because of reparative granuloma. And in case of permanent hearing loss, there can be suppurative labyrinthitis when there is a pus formation, suppuration. There can be trauma to the membranous labyrinth because of drilling or excessive stapes movement during the surgery. Trauma to the membranous labyrinth, a very long piston which is actually causing trauma to the membranous labyrinth, and loss of perilimb. So all these things can actually lead to permanent sensory hearing loss. And if there is a permanent hearing loss, you see that there is a sensory hearing loss patient is developing post-operatively, then you should treat it with steroids. Causes of immediate sense hearing loss is surgical, which we have discussed. Delayed hearing loss can be because of perilymph fistula. There could be hearing loss because of stapedectomy, because of presbycusis, and because of hydrops, which can be coexisting with the otosclerosis. Treatment is steroid, bed rest, and ultimately hearing aid. Repetitive granuloma. This is also one condition which has been described. I have not come across any case of repetitive granuloma post-operatively, and it is suggested that it is because of the gel foam and it is because of the surgical glove powder. There is a foreign body reaction and there is a granuloma formation at the foot plate area. Usually presents after 2 to 3 weeks of post-operatively, and patient has initially good hearing, which is followed by high frequency hearing loss and associated with tinnitus and vertigo. The management, when you examine, you will find reddish discoloration of the posterior half of the tympanic membrane. What is the management? You have to actually explore the middle ear and remove the granuloma. In spite of doing a surgical intervention, there can be hearing loss, and the steroid has a role in these patients. Caudal tympanic damage, yes, it can occur during the surgery. Again, I have already told you about the stretching of the nerve. You should avoid stretching. If it is coming in way, you can cut it, but avoid stretching. Most of these patients, intelligent patients, will actually come with complaints of caudal tympanic damage, complaints of taste disturbance after the surgery, and you must take a consent for this. Tympanic membrane perforation, if it is there, you have to use you proceed with the surgery. If there's a perforation which has occurred during the elevation of temporometrial flap, don't stop the surgery, proceed with the stepedotomy, put the piston and repair the tympanic membrane in the same sitting. You can use a temporal fascia graft or a tragal pericondyle. I usually use a tragal pericondyle if there's a perforation in the tympanic membrane during the stapes surgery. Vertigo usually occurs for a very short duration after surgery, and it is because of the small amount of perilymph leak. If it is prolonged after stapedectomy, it could be because of serious labyrinthitis. Persistent vertigo can be there because of long piston. So if you have inserted long piston, the middle end of the piston will be irritating the vestibule, and patient will have persistent vertigo. In these patients, you might have to revise the surgery. You might have to remove the piston and make a smaller piston to be inserted. And there can be also repetitive granuloma. Again, these patients of repetitive granuloma has to be surgically operated and treated with removal of the granuloma. Recurrent conductive hearing loss. So this is also one of the problems. You have done a stapes surgery. After the surgery, on table patient had good hearing, but post-operatively there is a decreased hearing. So immediately what can happen? There can be a misplacement of the processes. The processes might come out of the middle end of the foot plate, or it has come out from the incus, or there is loose processes around the incus. So all these conditions can be there. So malpositions processes, and there could be unrecognized malaise and incus fixation, unrecognized round window obliteration, unrecognized superior cerebral canal dehiscence syndrome. So all these things you must be ruling out in the pre-operative workup, right? So this is important. Middle ear effusion and trauma. Delayed causes can be slippage of the incus of the prosthesis from the incus because of erosion of the long process of incus. Malposition prosthesis, fibrous growth over the old window or round window, which has hampered the movement of the prosthesis. Adherence of the edge of the old window niche. There could be stapes refixation, and there could be progression of disease with rehabilitation of the old window. So these are the delayed causes. Far advanced sclerosis, otosclerosis, this entity has been described in the books. What do you understand by far advanced otosclerosis is that there is an extensive involvement of the cochlea, and the patient has air conduction threshold of more than 85 decibel, and there is no measurable bone conduction. So this patient will actually require a stapedectomy and conventional hearing aid or a cochlear implant. So most of these patients at present will be treated by a cochlear implantation, and patient with preoperative speech discrimination of less than 30% and severe changes of CT scan and small AB gap should be considered for cochlear implant. There is a role of BAHA also. If the patient is having only hearing aid then it has you can actually use a conventional hearing aid. But if the patient is not able to use a conventional hearing aid because of canal stenosis, or there's a mastoid cavity, or there's a post-fenestration cavity, then you can use a BAHA also. There's no risk of dead ear that may result from stapedectomy in these patients. That is the advantage of BAHA. So people have been doing microscopic stapedidotomy since long, but now the endoscopic stapedidotomy has come in vogue, and there is this definitive advantages of endoscope over the microscope. And here is the picture which you actually take it from the tunnel. So when you are entering into a tunnel and you take a picture from one end of the tunnel, you will see a very small area of the outside world, right? So this picture has been taken from the one end of the tunnel, right? And this is similar to a microscopic view. So what you are doing, we are actually using a microscope. The objective of the microscope is far from the area of exposure or area of the surgical interest, right? So this is a picture in cases of microscopic. And when you introduce an endoscope, the tip of the endoscope can actually go beyond the tunnel, right? And what you can have a very nice view of outside, right? So similar is the case with the middle ear. When you can take the endoscope tip close to the middle structure, you have a wide, high resolution view, and the view is uncomparable to the microscope. So that is an advantage, but there are certain limitations of endoscopic ear surgeries. So this is a view which is seen on microscope, and this is a view which is seen on endoscope. And this view is possible only because of the fact that the tip of the endoscope can be taken close to the structure, and it gives you a wide angled, high resolution view, right? So what is the setup? We use 0 degree and 3 mm endoscope. We use a HD. So all this setup is almost similar to a FES surgery. We use routine instruments with some modifications, right? So these are steps of, I will not go into because we have a video. What are the merits of the endoscopic stapedidotomy? We have a very high quality image, high resolution, wide angle view, adequate identification and visualization of footplate area, minimal manipulation of chorda tympani, minimal curettage of posterior bony wall, and no conversion to endoral approach. There are demerits also. There are problems that it is single-handed technique. There is a lack of depth in vision, longer operative time, which is relative. Once you start doing endoscopic stapedidotomy, you will find that your time has actually decreased and you take less time than microscope. It's a single-handed technique and has got long learning curve. So we did a comparative study of endoscopic stapedidotomy and microscopic stapedidotomy data institution, and this was published in one of the journals also. So this is basically, I had gone to COS Clinic, which is one of the pioneer centers where stapedidotomy has been performed. And I went there in 2011. Dr. Robert Vincent, at that point of time, had completed 5,000 stapes. So this is one center in the world which does maximum stape surgeries. And during my visit, he showed me a data of 5,000 stape surgeries which he has performed, and now obviously it must be many more. So now I will share the video of stape surgery. Just a minute. I have to open this video first and then share.
So you can stop sharing. Yes.
Just a minute. I have opened it and then share. Okay, can you see the video now?
Yes, sir. Please do.
Okay, so this is a video of endoscopic stepedotomy, and I mean there is a definite advantages because it gives you an unparalleled view of middle ear, right? Initially, when I started endoscopic stepedotomy, this was a thesis topic of one of our students, and during the surgery, what she used to do, she used to just, because the canal is tortuous, and every time when I introduce the endoscope or the instrument, it will actually strike the canal wall. So she used to just pull the pinna during the surgery, right? So her work was only to pull the pinna during entire surgery. But later on, what I started doing, I started taking this Tarabachi stitch. Tarabachi stitch is basically a canal stitch, which is taken from the cartilaginous portion of the canal, and it is then retracted. The canal and the pinna actually gets retracted because of the stitch, and it straightens the canal. So this is what I have started doing now, and it actually gives you a straight canal, and you have good good movement of the instruments and the endoscope without any problem, right? So next step is basically you give an incision, which is a classical Rosen incision, right? From 12 o'clock to 6 o'clock position, and the incision is given by a circular knife, and you start raising the flap, right? So once you reach the annulus, you should use a sharp instrument. So here what I'm using is a bishuri to elevate the annulus, right? And this annulus should be elevated till you see the round window. So here you can see the round window niche area, and superiorly also you should elevate the flap so that you can actually see the neck of the malleus, right? So that is the extent of the flap raising, right? And once you have elevated the flap, next step is to identify the chorda, right? Again, what you must have seen that I entered the middle ear in the inferior part of the middle ear, because if you enter superiorly, you might damage the chorda, right? So next step is to retract the chorda gently. Do not overstretch it, because overstretching can create problem, right? So once you have retracted the chorda, you just try to visualize what all structures you can see. So the chorda has been retracted, and the chorda should actually stick to the undersurface of the flap. So that is the best way. So now what you see, you can see the foot plate. You can see the tensor stability tendon, the pyramid, the facial nerve. Everything is seen, but the problem is that you will not be able to manipulate any instrumentation. So it is important to curate. With endoscope, you can see all the important structures, but for instrumentation, you need to create some space. And for creating this space, you have to curate the posterior superior canal wall. So this is after the curettage of the posterior superior canal wall, and you can see the nice view of all the important structures now, right? Now, next step is to check for the mobility. You can see that mobility. The incus is, I'm moving the malleus, the incus is also moving. Now you move the stapes. So incus is moving, but the stapes foot plate is not moving, right? So that actually confirms that yes, there is a fixity of the foot plate, right? Now, what you do, once you have confirmed the fixity of the foot plate, you dislocate the IS joint, right? So this location is actually done by a curved pick, or if you have a joint knife, you can use that. So slowly dislocate the IS joint. Okay. At this point, you should be gentle, because you want to dislocate the IS joint, but not the incus, because moving too much of incus can actually dislocate the incus, right? So here you have to be gentle. Next step is to Now, after dislocation, you have to cut the stapedial tendon, right? So I'm using a scissors to cut the stapedial tendon, and the stapedial tendon should be cut close to the pyramid, right? So, this is the stapedial tendon which has been cut. Okay. The next step is to fracture the crura. So the posterior crura. Now you can see the posterior crura is very clearly seen, and you can also see the foot plate. The posterior crura is fractured, and it should be fractured downwards, not the in the direction of the foot plate, right? So once you remove the foot plate, this is the whole superstructure which has come out, right? At this point, you can actually use a laser, handheld laser if you have. You can also use a skeeter to drill the posterior crura and then remove the foot, remove the superstructure, right? So just fast forward it. Okay, so the superstructure is now removed, and what you can see here now is the foot plate, right? So this is a foot plate which is nicely seen, a blue lined foot plate. Now you have to measure the foot, the process, right? So this measuring rod, it is actually, this is the 4.5, right? So it is coming lateral to the incus. So you should measure from the middle end of the incus till the foot plate, right? So once you have measured, this was around 4.4 millimeter and 0.25 millimeter added for the foot plate length. So 4.25 was the length. Now you have to, I'm using a perforator, 0.7 mm perforator to perforate the foot plate, right? So it should be very gentle. Just rotate, don't put pressure. You have to just rotate the perforator over the foot plate, and it will just give way, right? Next is to cut the piston of appropriate length. So this was around, I think, 4.25. So you cut it, use a jig, cut the piston at the appropriate length, and then you have to open the piston, right? So just gently open the loop of the piston. Don't open too much, because if you open too much, what will happen? It will lose the memory. So we want the memory to be there, right? And then the piston is held from the loop by a crocodile forceps, right? And then it is inserted. So the lower end of the piston should go first into the foot plate, and then you slide the loop around the incus. So that is the placement of the process. And now you have to crimp. Crimping can be sometimes difficult in endoscopic surgery. You have to be very gentle because your only one hand is working, right? So just crimp it gently with the crocodile forceps, right? And once you have done the procedure, I'm just trying to replace the chorda in its position, and then you reposit the flap back. So this completes the procedure. You may check the hearing on table, and after checking the hearing, I usually pack the external aortic canal with medicated Ciplox medicated gel form. So that completes the surgical video. So I think I have finished with my presentation, and so thank you very much. I would be happy to answer any questions if you have.
Yeah, if there are any questions, they are most welcome.
So I can see some of the questions in the chat box, and with the permission of the moderators, I can start answering them. Okay, so the first question was, is there any data available in Indian population or estimates of otosclerosis prevalence? I don't have any information about the Indian data, but the otosclerosis is very commonly seen in southern part of the country. What I have, heard, and I have come to know that it is very prevalent in southern part of the country. In Asians, it is less, but it is a more of a disease of a white race. Second, how do you rule out Meniere's disease? Okay, so Meniere's disease and Meniere's syndrome, there are two things. If you are confirmed with the diagnosis, it is called as Meniere's disease. But if there is a component of vertigo, hearing loss, and tinnitus, it comes in Meniere's syndrome. And the Meniere's syndrome, one of the cause for Meniere's syndrome can be otosclerosis also, because otosclerosis patient can also present with hearing loss, tinnitus, and vertigo. So how to rule out? If the patient is having low frequency hearing loss, there is a component of tinnitus and vertigo, and it is episodic, then you should think of Meniere's disease, and you can actually get further investigation, and the investigation of choice is actually electrocochleography and WEM. So if the electrocochleography is positive for Meniere's disease, it is actually Meniere's disease. You have to suspect that this could be Meniere's disease, right? So suspicion is important. Okay, which endoscope do you use? I am using 4 mm, but of late we have started using 3 mm also. 3 mm endoscope is ideal for endoscopic ear surgery because it will give enough illumination and good quality picture without compromising on the space. Because if you use a 4 mm endoscope, you have an slight more thickness of the endoscope and less space available for instrumentation. So even a 1 mm space is important in external canal. And if you use a 3 mm endoscope, it will give you fairly good image quality, and there's no compromise on the resolution part. And you have an extra 1 mm space for instrumentation also. So that is the endoscope which has been recommended by International Working Group of Endoscopic Ear Surgeon. 3 mm endoscope. Okay. Any role of incus remodeling and kept between stapes footplate? Remodeled incus can be a good choice if you have intact suprastructure. But here what is happening? The footplate is fixed. So you have to remove the suprastructure. You have to make an assembly from the footplate to the malleus. So how can you make that? You can do either use an incus replacement prosthesis, which is like a L shape, or you can use a TORP, total ossicular reconstruction prosthesis, or you can do a malleus relocation or malleus posterior relocation of malleus, which is described by Robert Vincent.
Hello, Ravi. Hello, Ravi.
Yes,
Can
yes,
I
sir.
ask you a few things?
Yes, sir. Please, sir. Please.
I have few comments and few queries
Right, sir.
for CT scan pre-operatively. But shall I teach our
Definitely, sir. You please.
postgraduate
Yes, sir.
students
Please, sir.
now
Please.
at present time? Shall we not tell them that we should go for CT scan in all the cases,
Yes,
not
sir.
only in special circumstances?
Definitely, sir. I mean, if you have the facility of CT scan, you should go for CT scan in all the patients. And of late, we have started doing the same. We actually get CT scan in all the patients, and you will be actually
Yes.
surprised to see some of the findings which we actually miss if
Yes.
we don't get a CT scan, right?
Yes.
So it is always better to get a CT scan done.
So here we will like to tell our postgraduate students and the young ENT surgeons that let us do the CT scan. If it is not available or patient can't afford, is a different thing. The second query is how frequently and how many people are prescribing sodium fluoride these days?
Sir, just for sake of completion, I actually mentioned sodium fluoride as well
many
as
side effects you have enumerated.
yes, sir. But sir, I have
osteoclast.
not seen any. I have not seen any surgeon or any ENT surgeon prescribing sodium fluoride. I don't know,
I would
maybe
like
ours.
to, I would like to ask this from anyone who has been using sodium fluoride, from the group of 60 ENT
The
surgeons who have joined
senior
today.
people must be using it. Senior, very senior people.
I am asking senior only.
May I?
Yes,
May
sir.
I?
Yes, sir. Yes, sir.
Yes,
I have
yes.
used in one patient only. That was in 2003. That was a patient of typical otosclerosis. There was a SWOT sign positive, and the patient was given sodium fluoride. The drug was not available in Chandigarh. It was made available in Delhi. I think Nath Brothers was having it. So
Yes,
the
sir.
answer was taken from there, and patient took it for 1 year or so, and the active focus stabilized. And after that, patient was given hearing aid because he didn't agree for surgery. One patient only I have.
What was the result? Observation.
Her SWOT became absent. SWOT
Hearing improved or not?
Hearing was the same. So she was given hearing aid. She did not agree for the surgery.
The another query is, Ravi, can we tell the patients if patient is having associated tinnitus, that tinnitus will go away? Can we tell? Shall we tell this preoperatively?
Sir, usually the tinnitus disappears after a successful otosclerotic surgery, but we should not give guarantee. You can actually say yes, it might improve, but we are not very certain. You should not say that 100% your tinnitus will go. That statement should not be made to the patient.
About the type of anesthesia, Ravi, if I say that beginners should do it under general anesthesia in the beginning, whether it is endoscopic or microscopic, for the sake of at least immobility of the patient, will it be right? I know you people are doing under local anesthesia.
Sir, again, it depends on the surgeon's comfort. If the surgeon is comfortable in general
I'm
anesthesia,
talking
there is
about
no harm.
beginners. I'm talking
Yes,
about
beginners
beginners.
also beginners also can. In fact, when I went to POS clinic, sir, Robert Vincent used to do 3 to 4 stapes every day, and all the surgeries were done.
I'm talking about
under GA. Under
I'm
GA.
talking
He used to do under GA.
Senior resident who is
Your voice is breaking, sir. Voice is breaking.
I am talking about a senior resident who is about to complete his SRship or her SRship under senior people. I am talking about beginners. Hello, Surinder.
Yes, sir. Sir, I think under supervision, they can do under local anesthesia because they are doing laryngoplasty under local anesthesia. The only difference is in this case, it's a virgin case. The ear is absolutely dry inside and they can expose it. And when they make the fenestra, you should be around and the proper sedation to the patient is given so that the patient doesn't move at that time. That is the only problem. At the time of making a fenestra, the patient can move. He can have a sense of vertigo. That is the only point where patient will be worried. Otherwise, I don't think local anesthesia is a problem.
Dr. Pasi,
Okay.
can I make a point, please?
Yes. Yes, Dr. Rai.
Your basic aim is that the patient should remain immobile during surgery. There are chances in a local anesthesia that once you open the middle ear, the patient, if not given proper anesthesia, he may move and have serious consequences. So the basic point is that patient should not move. You can use any type of anesthesia. Make sure the patient is not moving. Nowadays, we are doing under
you can assure this under GA, not under local.
And that's why people should do under GA. And if you go to a country like Middle East, they say our patient should not have any amount of pain due to surgery. So even in the Middle East, we are removing pack and the stitches of the mastoid patient under general anesthesia. That is the point. Another point that in our institution nowadays, we are doing all stapes patient. The CT scan is a must because we do not want to miss the chances of pathology which can be seen and ruled out by CT scan.
My last query, Dr. Ravi, is about the experience of my colleagues, were the operators about operating the second year.
Okay, sir. Sir, I mean,
Second
recently,
year.
sir, Sir, recently I was not operating second year, but recently one patient came. I had operated this patient in 2017,
Surgery.
endoscopic stepidotomy.
Surgery
and
on the contralateral side.
He
Hello.
came with a request to get his surgery done on the other side. He was having a good hearing from the operated ear. मैंने पूछा कि why do you want this? He said, I am a teacher and I find difficulty in hearing when the student is speaking from this side, from the non-operated side. So I want to have a binaural hearing, and in fact, I operated this patient on the other side also last week only. I mean, last OT only we operated this patient, and patient has good hearing and now in both the ears. So if there is a demand from the patient, there is no harm in doing a revision surgery. But yes, if there is a complication in the first surgery, if you find that there is a difficult, there's a facial overhang, or there's a narrow round window niche area, or there is a complication, if there is some problem in the first surgery, I would not operate the other ear. I will give him a hearing aid.
So in case we have a failed surgery on
Yes,
right
sir.
ear, so will you operate on the left or not?
No, sir, I will not. I will not. I will send this patient for, because I want to preserve this hearing.
Operate on the right side only.
Dr. Pasi,
Yeah.
hello, am I audible?
Yes, Ishwar. Yes, Ishwar.
One of my close relative had undergone this thing, stapes on one side, and
Okay.
it was operated by Dr. Kakkad, Dr. S.K. Kakkad. And sir advised for the second year surgery after 2 years. So then the patient underwent second surgery.
Patient
after
has every right. Patient has every right to get the other side also operated.
Yeah,
Yes,
but
don't
the
say
time
that, but-
suggested by a stalwart like Dr. Kakkad was 2 years.
3
The
years.
gap between the first and the second year.
Yeah.
Ravi,
Yes, sir.
Ravi, I have a few comments to make.
Yes, sir.
First is a query, as Dr. Pasi also asked you. How
Yes, sir.
common is CSM and otosclerosis you diagnose?
Sir, I mean, there must be definitely, we are missing it. We are actually missing it. There is if you see the incidence, it is around 1%. Stapes, का जो incidence है, it is less than 1%. And
1% of what?
Of histological otosclerosis. So histological otosclerosis का 1% होता है. Basically 10% histological otosclerosis होता है common, and 1% of that is clinical otosclerosis. So
there was a
I don't
question
think, sir,
for you.
we have to look for specifically for a fixity of foot plate during the mastoid surgeries or routine CSM surgeries. And if we have to suspect it, then only we'll be able to diagnose it, right?
Because in a CSOM there will be conductive hearing loss. In a otosclerosis there is a conductive hearing loss.
Yes.
So how do you differentiate between that?
So that is
query.
Yes, that is a difficult situation. Then you have to actually check for the mobility of the foot plate during the surgery. If you are operating a CSM patient, then and you are doing an osteoplasty, that at that point of time you have to check for round window reflex. If you've done an osteoplasty and a round window reflex is absent, you must suspect a stapes foot plate fixation.
The other question somebody asked you was, just hold on. The other question somebody asked was, how much was the conductive hearing loss in Indian scenario, or that Indian scenario otosclerosis was asked, and you answered in South India. Refer to the 4th recent advance of otolaryngology, and in that there is a reference, and it is 30% of the conductive hearing loss is otosclerosis in South India.
30%, sir, it is too high, sir.
Too high.
I can't believe it.
South, you can refer, you can check it.
Achha,
I am
sir.
quoting you the book also. It is
Achha,
4th
okay,
recent
sir.
advance.
Achha, sir.
The,
Okay, sir.
The other question is, in audiometry, how much gap you set to before you subject the patient to operate? 15 dB you commented.
Right,
What
sir.
is your reference?
Sir, the reference is Scott Brown. And I have seen, sir, patient getting surgery for even 10 decibel hearing loss. So it depends on the patient requirement. a 30 decibel hearing loss will be an ideal patient, because that will actually show good on the pure audiometry, and the improvement will be significant. But if the patient is having problem in hearing, a 15 decibel patient should also be operated.
The latest,
This is the recent,
latest OCNA on otosclerosis. Latest OCNA on otosclerosis. It shows that minimum gap should be 30 dB, and if that is there, then the chances of floating foot will be minimized, because that will have a good impact or anchoring of the foot plate, and it will
Right.
not lead to the floating. So, as per the OCNA I read,
okay,
it is 30 dB.
Agreed, sir. That is that is a very valid point.
The other question I am asking is, what is a functional stapedectomy or DOTMI? It may be asked to the PGs in the YYYC. That is,
so basically, sir, you preserve the stapes stapedal tendon.
So
Yes.
the incision, so instead of separating the IS joint, you cut below the attachment of the tendon, so that it remains, so that protective effect of the stapes is still there in spite of removing the structure below the stapes.
Absolutely, sir. So there have been, sir, attempts to actually glue the stapedal tendon back to the prosthesis also. I mean, there have been
just
some,
like your cruciate ligament in the knee joint.
Yes, but again, I mean,
expert hand is required.
Difficult thing.
It will pull your processes down if you do that. It will pull your processes posteriorly if you glue with the processes, the tendon.
But if you rotate the handle also, then doesn't it come down to the stapes area? That long process of handle of malleus.
Handle of malleus.
The other point you said was again a PG question. In case of obliterative focus handheld drill which is used, that may be a standard YYOC question, and that is Larkin's drill.
Larkin's, but I actually there was a mention of Larkin's in the PPT, but I skipped it.
Okay. And to thin out the posterior superior wall, the skitter can be used before you open the middle ear. So that will ease in curating also. That is one step which can be added. So you covered it, that's use of skitter during the fenestration or opening the stapes foot plate.
Skitter is actually for the fenestration and the posterior crura, but you can use a 1.5 millimeter drill bit to remove the bony overhang before opening the middle ear. So before,
so that the dust doesn't go in.
Before elevating the annulus, you can actually drill the posterior superior canal wall and then elevate the temporomandibular flap, and then curate the remnant of the remaining part of
once it's thinned out, it's easy, because otherwise chances of dislocating your long process of incus will be minimized, because it will be thinned and you will not take a big bite.
Right, sir.
So over to you again.